So, to set the stage for my talk today, I'd like to introduce everyone to a patient that I have taken care of as an infectious diseases physician during my time when I'm working in the hospital. So, not only do I do research, but I also see patients as well. So, this patient's name is Roberta, and she is in the hospital to receive chemotherapy when she starts to develop fevers and chills. So Roberta actually had a planned hospital admission. She receives a type of chemotherapy that requires close monitoring. So we had admitted her to the hospital so she could safely receive her treatment. And she has something called a PICC line in place that some of you may be familiar with. It's a more permanent version of an IV that folks receive when they're in the hospital. Usually goes in one of the two upper arms, and people can leave it in when they leave the hospital. So it's a really convenient option for people who may require IV treatments intermittently or when they leave the hospital as well. With Roberta's symptoms, we did a little bit of a workup. We wanted to get some blood work, get some samples to see what could be causing her symptoms. And unfortunately, we found that Roberta's blood cultures were positive for bacteria that required antibiotics. So there was bacteria growing in her bloodstream, and Roberta had something called sepsis, which some of you may have heard about before. And while Roberta was getting the care that she needed, her family was a little bit confused as to why this happened. They had questions. Roberta's in a hospital. This should be a place where people get healthy. Why did she get sick? So today I'm going to start by talking about something that's a big problem in our hospital system called healthcare associated infections, or HAIs, like I'll be talking about through the rest of my talk. These are a major threat to individual patients. They are found significantly in patients. 600,088 HAIs occur in US hospitals annually. And when people get sick from these, they are at risk of dying. There are over 72,000 deaths every year related to HAIs. And while it's devastating for patients and their families, these infections also take away resources from the rest of our healthcare system. There's $28 billion of excess healthcare dollars spent on HAIs every year. So this is a problem on multiple different fronts. And so to answer Roberta's family question as to who's at risk for getting these HAIs, there's kind of three big categories I like to think about as an infectious diseases physician. The first are patients that are immunocompromised. So patients like Roberta that are receiving chemotherapy. Like our last presenter just spoke about, it kills healthy cells in our body in addition to cancer cells. Things like being critically ill. So if you're in an intensive care unit, your body may not be able to fight infections like it could if you're, otherwise healthy. Antibiotics, while they're great at killing bacteria, can also have some untoward effects as well. Antibiotic resistance is a very big problem. Bacteria, when they encounter an antibiotic, can become smart and figure out ways to work against antibiotics. So actually receiving antibiotics can put patients at bigger risk for developing infections. And then finally, indwelling devices. So things like Roberta's PICC line that I mentioned. Some of you may have heard about a tracheostomy before, a breathing tube that goes in the neck. Anywhere where there's a device that goes from the outside of the body to the inside of the body oftentimes allows bacteria to get into those spaces and cause infections. Bacteria also love to grow on things that aren't our bodies. So they love to grow on plastic. They form things called biofilms, which are communities of bacteria that become very difficult for antibiotics to enter and cause infections. And so how do we decrease healthcare-associated infections? Research has shown that 30 to 40% of our HAIs are actually preventable. And there are three different spaces we think about preventing these HAIs. The first is with the patient themselves. So there may be procedures or treatments we can give to patients to help reduce these HAIs. There's things in the immediate healthcare environment, so the patient's room itself. We may have waterless hand sanitizer around the room. If you've been in a hospital before, you may see healthcare providers come in with masks and gloves and gowns, so they're not moving bacteria from one patient to another. And then even things about the healthcare facility actually can help prevent HAIs. So we have an entire team of healthcare engineers that we work with that design things like safe plumbing. Bacteria live in water. So how do we make sure the bacteria that are in the water don't get to our patients? We are able to do things like have patients be in separate rooms so that you don't have a neighbor that you may be sharing bacteria with. So today, as kind of my video alluded to, I'm going to be talking to you about a intervention that we do at the patient level, so directly to patients to help prevent HAIs. And that patient intervention is the use of an antiseptic soap that's called chlorhexidine dichleuconate, or CHG. This is used in healthcare settings to help prevent infections. And CHG can look like a variety of different things. Typically, with all of these forms, we use it to bathe patients. So rather than using soap and water, we use this special soap to help clean patients in the hospital. We can do this by using wipes. So the CHG is actually in the wipe for those of you who may have little ones at home or change a lot of diapers. They look similar to a wipe like that. We also can use either a foam or a liquid that we put directly onto a washcloth and clean patients in that way. This is called HibaCleanse. Some of you may have even seen this at CVS or Walgreens. It's sold over the counter. We also have specific spot treatments with CHG. They come in little swabs like this. We use this to clean the skin at specific areas where we may be inserting an IV line or doing a surgical procedure, so it gives a more concentrated cleaning. And finally, CHG actually comes on special discs that surround things that are coming out of a patient. So one of these we may put around a PICC line like Roberta had. This provides continuous disinfection or antisepsis so that bacteria don't get into a patient's body when they have a more permanent device that's in place. So here's what we have found with our studies looking at how effective CHG may be. Daily CHG bathing, when patients are in the hospital and may have certain risk factors, reduce the risk for HAIs. And not only does CHG reduce the risk for just all HAIs, it actually reduces the risk for HAIs with antibiotic-resistant bacteria. Again, those really scary bacteria that can get smart, work around our normal antibiotics, and be very difficult to treat. And this is why CHG bathing is so important to me. I can't tell you the number of times I've actually taken care of patients where I have one, maybe two antibiotic options I can give them. So if I can prevent patients from getting these infections in the first place with something as easy as using a special soap for their baths, I'm all for it. So you can see here, this is research that was actually done at Rush. The black line are patients who have received CHG baths. You can see that they have a lower risk of a BSI or bloodstream infection compared to the gray line who did not receive CHG baths. And we found that there's certain populations in which CHG bathing is more effective. So we found that there's a significant benefit for patients that are in intensive care units or that are critically ill, immunocompromised patients, or patients that have permanent IV lines, so similar to Roberta at the beginning of our talk. We've also found that universal decolonization, meaning everyone that either has one of these conditions or is in one of these units in the hospital, should get the bath rather than trying to pick out, okay, this person's at a bigger risk or this patient may be at less of a risk. So doing daily bathing in an intensive care unit, for example, we would clean every patient in every room with CHG. And then we did find that when we did CHG baths for patients that were not acutely ill, so maybe patients who had been admitted for an elective procedure or for a joint replacement, we didn't necessarily have to do CHG baths for those patients. So while I'm sure you're all thinking, please bathe me in CHG. This sounds amazing. I would also love to participate in this. We do worry about the downsides of using CHG everywhere. How many of you have heard of triclosan before? So triclosan is an antibiotic that used to be in hand soap and used to be in household products. We actually had to take it out of those products because we were fostering antibiotic resistance in areas that we didn't want it there. So because CHG is an antiseptic similar to triclosan, we got worried that, is our widespread use of this product making these bacteria smart? Can bacteria develop resistance to these antiseptics just like they can to antibiotics? And so we started to look at bacteria that we found just on our surfaces in our intensive care unit at our hospital. You can see the different areas on the bottom of the slide where we actually collected samples from. And what we found was that there were certain areas of the hospital room where bacteria were able to grow in higher concentrations of CHG than what we were expecting. This was particularly interesting because this was happening in our sink, and the very first CHG product I showed, the wipes, are actually what we use in our hospital. So you're supposed to use the wipe and throw it away. There's not a sink involved at all. So this really kind of gave us pause and made us think, why are we seeing these numbers start to go up a little bit? Now, these numbers where they were growing, it's still less than the concentration of CHG than we use in our regular products. So bacteria were still being killed, but the trend itself was concerning enough for us that we started to worry about, well, what do these bacteria look like that are on patients that are getting bathes every day? Is there CHG roaming throughout our hospital? So we designed a project that had two main questions. So first, is CHG becoming less effective at preventing our patients from getting antibiotic-resistant bacteria? And finally, are bacteria where there's CHG maybe in the environment or in the hospital environment, are those bacteria more likely to be resistant or tolerant to CHG? So we employed a couple of innovative techniques to our research that were different than that first project that I mentioned. First, what we did is we actually looked at residual CHG concentrations. So rather than looking at bacteria and how they're reacting to CHG, which we also did, but we actually took a sample of the surface and looked for CHG itself. So when we're bathing patients, our question is, are we releasing CHG into the environment that bacteria then, can be surrounded by and get used to? This time we also collected patient skin samples, like I mentioned as well. So we're not just collecting bacterial samples from surfaces, we're also collecting skin swabs from patients to look for bacteria and see how those bacteria might be reacting to CHG. So the way that we designed our study is that we chose 15 hospital rooms where patients had been receiving CHG baths for at least 14 days, and also rooms where CHG was not in use at all. We collected samples both from patients, so we chose areas where CHG was in heavy use, so areas over the chest, the front of the hip where they had been receiving baths, and also an area where we didn't use as much CHG, which is inside of the nose. And then we looked at 4 different surfaces in healthcare rooms as well. So we looked at 2 surfaces that were close to the patient, that the patient and their healthcare providers were frequently touching, their bed handrail, and then their table that goes over their hospital bed, which some of you may be familiar with. And then we also looked at 2 areas that were a little bit further away from the patient where we weren't really expecting to see CHG. That was the light switch and the sink. So again, areas where we don't expect as much contact. And then what we did is we took samples and we first looked at the CHG concentration in our laboratory. And then we also grew bacteria from the swabs that we collected on surfaces as well as skin. We did a test called a minimum inhibitory concentration, or an MIC. And that basically is how much of either the antibiotic or the antiseptic is needed to kill a bacteria. So the higher the number that is needed to kill, the more resistant that bacteria is to that particular medicine or antiseptic. And so we found lots of different bacteria. Unfortunately, hospitals are still filled with bacteria despite our best efforts. We did find that there were probably an equal amount of bacteria growing on patient skin compared to the hospital environment. These are an example of some species that we found. You may recognize some of the names like Staphylococcus aureus, which is Staph aureus. One of the good things that we found was that when we looked at the CHG MIC, so again, that concentration of CHG needed to kill these bacteria, we weren't seeing unexpected numbers. The numbers that we were expecting to see were the numbers that have been validated to kill these bacterial species, which is very good news. And when we looked at our antibiotics, we did find 2 antibiotic-resistant bacteria, but they were in species that oftentimes do have antibiotic resistance in the hospital. So again, nothing concerning or terribly out of the ordinary. And then another promising finding is that we weren't finding any CHG in rooms where CHG bathing was not occurring, meaning the residual CHG was only close to areas where CHG was in use. So this wasn't being tracked throughout the hospital. It wasn't a compound that was, being moved from room to room by healthcare providers, which is really good news. You can see on the on what is your left-hand side of the graph that the most common places we found the CHG was the bed handle and the overbed table. So again, areas close to the patient where they likely got bathed and then touched. But we're still seeing some of that CHG in the sink. We don't quite have an answer for why that's the case yet, but something that we have thoughts about and something we'll be doing further research on. And then we ran some statistical analyses to look at both our MIC numbers and our concentration numbers. And what we found was that CHG MICs, or how much CHG is needed to kill bacteria, was not significantly elevated in rooms where CHG was in use versus rooms where CHG was not in use. The statistical significance we did find was that the levels of residual CHG, or those concentrations, on the skin were significantly elevated compared to what we found in rooms. But again, we expected this. We're applying CHG directly to the patient. So we expect them and actually want them to have a higher CHG concentration so that the soap is effective. But when we pulled out the bacteria that were in the exact same location where we collected those CHG residual amounts or those concentrations, and those concentrations were positive, those bacteria did not have significantly elevated CHG MICs, meaning the same amount of CHG was still needed to kill them, and that even though bacteria were growing in the presence of CHG, our data doesn't suggest that they're developing resistance to CHG. So I wanted us to go back to Roberta here in the hospital. So fortunately, she had a fantastic infectious diseases team taking care of her, and she did receive antibiotics to treat her infection. And then when we reviewed our infection prevention protocols, we determined she'd be a great candidate for daily CHG bathing, so that was instituted. Roberta unfortunately had a type of cancer that she did have to come back to the hospital about 4 more times to receive chemotherapy while she's in the hospital via her PICC line. But because of the intervention that we took, I'm happy to report that Roberta did not develop another infection during the course of her chemotherapy, which really highlights the safety and the effectiveness of this tool to help prevent HAIs. And so I thank you all for coming and for listening today, and I'd be happy to take any questions.